Alright, okay. Alright, so what we are going to do is catching the right sweet spot. That means looking at the right kilocalories. Okay, so इसको on किया?
Yes.
Sorry?
Dhanashree madam also.
I need her to come here. Where is she? Vidya is gone. Blood pressure. How do you monitor blood pressure? You all know how to monitor blood pressure, right? You all know how to do that, right? We monitor blood pressure by looking at a blood pressure cuff. Simple, objectively. This is what we do it, right? We actually look at blood pressure, right? Now, how do you prescribe kilocalories objectively? That is the big question that we want to try to answer, especially because of the fact that 50% of liver glycogen goes down. Okay, in the first week, 1% of muscle mass is lost in 24 hours. 1% of muscle mass is lost in 24 hours of trauma and fasting. So if you fast for one day, you will lose 1% of muscle mass. This is very important, and muscle mass is responsible for keeping your functional activity very good. If your muscle mass goes down, you go down. That's why old age people, their muscle mass is lower and lower, and that is why they don't function like the way other people function. Right? Now this is the study that we did. We all know the study. Muscle mass, we did the study in our place, and what did we find? We found a huge change in the muscle mass in 1 week. Okay, if this was, it's not just theoretical, it's actually there. So when we looked at muscle mass, we found that it dropped from 1.44 to 1.22. That was the amount it dropped. 0.5 centimeters drop ho jata hai muscle mass in 1 week of critically ill patient. That is 33% increase in ventilator load and fatty liver when excess of 500 kilocalories are given. That means if you overfeed by 500 kilocalories, you may not be able to get the patient off the ventilator. That can be a problem for those COPD patients. Okay, if you want to overfeed these patients, because 33% increase in ventilatory load. That means if you have to breathe 500, you have to breathe 750. If your mid ventilation is 6 liters, you need to breathe around 8 liters, which is going to be a load onto this patient, right? So this problem is there, and 50% of these patients who actually have these problem critical care, you don't reach to full functional status even at 3 months. Okay, and a 1,200 kilocalorie difference in the whole day, in the whole admission, will actually portend a survival disadvantage. That means your calorie requirements have to be actually matched to what the patient should receive. Okay, we know that sepsis mortality is coming down. That is very clear. We know that sepsis mortality is coming down. But what is happening is the admission to rehabilitation centers have actually gone up by 3 times. Okay, this is what has occurred. Okay, now we know sepsis mortality is coming. There is no doubt about it. But what is happening is that death in the first year is increased by 50%. How many of your patients you seen coming back alive normally? Those who are very ill. Most of them actually are lost. How can they be lost? They are actually dead. 50% of them are actually dead. If they are into intensive care unit, they are on vasopressors, CRRT, the works, mechanical ventilation, 50% of 1 and 2 will die. You will not see them back. This is the harsh reality that we have with sepsis and these things. And they also go into very severe ICU weakness and recovery. This is what a very important article that came out. It says about ICU acquired weakness. Many of them go to an ICU acquired weakness to an extent that they can't even go to the toilet. They can walk and go to the toilet. If you ask your patients who've been in the ARDS and all these things, how's your status, they say we can't come and meet you. Why they can't come and meet you? Because they can't even travel. So difficult for them to travel also. They don't come and even come to your hospital. It's so difficult for them. It's so difficult for them to travel. So it's because of ICU acquired weakness. And that's probably because we have 2 things here. We have SIRS and CARS. Okay, what is SIRS and CARS? SIRS is systemic inflammatory response syndrome, whereas CARS is counter anti-inflammatory response syndrome. So initially there's an inflammation, and then the counter-regulatory hormones come in to reduce it. So when this balance gets dysregulated, the sepsis becomes very bad. When this balance gets dysregulated, so when we talk about sepsis and we define sepsis, we defined it as, it's a very broad definition. Dysregulation of immune system. This is what it's a very broad definition. But in short, it's a combination of a lot of SIRS and CARS that happens together. Okay, that means SIRS, the initial SIRS definition will actually call about temperature, WBC, all that works. It actually works. Okay, but only that it's not the different definition that you have to use. So SIRS and CARS, the 2 things that occurs. Initially we thought that SIRS will occur, then CARS will occur. We initially thought SIRS will occur, then CARS will occur. That means there will be a period of inflammation, then there will be a period of counter-inflammation. But now what we know is it's not like that. It is together. The SIRS and CARS are occurring together. So that's why it's called dysregulated immunity. Okay, you have SIRS and CARS are occurring. It's an absolutely maladaptive response that occurs to these patients, and that's why it's no longer SIRS going to CARS, but it is a complete dysregulation. And this is how critical illness I perceive. It's a monster. It's like a monster. And when you look at this particular study, it's a very old study, 98 or something. This study was done. It was done by a person called as Lindsay Plank. And a very beautiful study that actually looked at metabolic response in severely septic patients. Okay, during the first 23 days after onset of peritonitis. So she looked at patients who were 23 days after onset of peritonitis, and I'll open this graph for you and to understand this graph well. So what happens over here is, this is 25 days, okay, after admission, and this is the resting energy expenditure. Okay, resting energy expenditure. What is resting energy expenditure? So whenever you are, what is resting energy expenditure?
The energy of burning by your basically
What is total energy expenditure? So there are few assets. So the total energy expenditure is the addition of resting energy expenditure, diet induced thermogenesis, and activity induced energy expenditure. You understand? So a DIT or a what do you call that? A resting energy expenditure. I mean a total energy expenditure. Understand these terms very clearly. Okay, if you don't understand, stop me. Ask me. It was a very long lecture. This is okay. Total energy expenditure is equal to resting energy expenditure plus activity induced energy expenditure plus diet induced thermogenesis. Okay, diet induced thermogenesis. Okay, this is what it is. These two factors are actually very low. Is this factor that is very important, and we don't expect our patients to be exercising. So that's why activity expenditure is not what is counted. We are looking at resting energy expenditure, which is basically the energy required to maintain your muscles, maintain your cardiac system, maintain your respiratory system at the state when the patient is lying down over there. That is your resting energy expenditure, right? So your maintenance expenditure is resting energy expenditure, right? So they looked at REE here. They looked at REE here. Now, long ago, they were using REE by using something called as delta type monitors, which are very, very large and cumbersome monitors. We'll come to that when we come to understand what these things are about. Okay. So when they looked at that monitor, they found resting energy expenditure. What's important for you to know is when you're looking at resting energy expenditure here, it was actually up, going up, then going down, then remaining high for more than 24 days. It's remained high for 24 days. I mean, it's a very long time, na? After peritonitis, it's like a month. A month, the energy expenditure was high, but when you predicted it, it's just a 25 kilocalorie per kilogram prediction. It remains there only. It doesn't change only. By weight reduces, that's why thoda kam ho gaya. Otherwise, resting energy expenditure is very, very different. Importantly, at 9th or 10th day, there seems to be a very big rise in resting energy expenditure. It looks like that. In most of the studies, it looks like that per se. This is exactly what happened in our study also. In our study also, when we looked at, firstly, when we were doing energy expenditure 6-7 years ago, we used to find something like this, and we published this one of the white papers. It actually went up by day 9, day 10, it started going up in our patients also. So somewhere on 8-9 days now, the energy expenditure starts going higher up. Alright, now importantly, it remains high for more than 20 days. That is very important. It remains high for more than 20 days. Just take the phone. Tell them later. Okay, it remains high for 20 days. Now, look at this graph. Now, this graph is the same patients. Now, in this graph, very importantly, what you're looking at, this triangle. Okay, this pre-albumin. This is what you're seeing over here is pre-albumin. Okay, what you're seeing over here is CRP, right? And what you're seeing over here is transferrin. So what you're seeing is that CRP, though the CRP is coming down, okay, though the CRP is coming down, the albumin is still not, still requirements are on the higher side. Loss of albumin is still high. So you don't pick up albumin though your inflammation is gone. The issue is that your albumin still remains low, pre-albumin still remains low, even after inflammation is gone. Okay, which basically indicates that the inflammatory phase is very high. So that's why you should understand two important terminologies. What is homeostasis? Homeostasis is what? Whatever your body does to keep your temperature normal, your pulse rate normal, your BP normal. This is homeostasis. To maintain all your vitals, that's called homeostasis. What happens is that once a patient gets ill, he moves from a status of homeostasis to an elevated state called as allostasis, which is the new normal. You understand? So for a long period of time, the person will remain in that new normal, a new pulse, a new BP, a new inflammatory condition. So that will be his new normal. That's called the new normal. That's called allostasis. Alright, now let's take the example of a patient. Okay, so here a patient who basically was healthy. He developed some kind of an acute critical illness. When he developed an illness, there was an initial stressor that came in, which actually increased his allostatic load. Okay, reached over here. Say for example, here on day 3, he got maybe operated or things like that. If he got better, allostasis came down and he went into a prolonged critical illness recovery phase. Okay, but he went into a critical illness recovery phase. Who's that? Satish, you phone push on. Satish. Then from here, somewhere it goes up over here. Okay, So now say for example here this was the patient. If the patient worsens, the allostasis again goes higher and higher. Okay, this is what happens. Now say you did a tracheostomy. Your tracheostomy allostasis, patient starts improving again, the entire homeostasis starts getting better and better and better, but it takes time, it takes time to go into that phase. Now here, at this point, when stasis is getting maintained, you do something wrong. You do something wrong at this time, and that something wrong you do somewhere over here. Okay, either it may be underfeeding or overfeeding. This is exactly what you're doing at this time. At this time, there is no infection, there is no nothing. You just do something like underfeeding, overfeeding. This entire thing will have a problem. Okay, you understand? It will go to a situation where the patient's allostasis will never recover, and patient goes into chronic critical illness. So it's important to pull back your patient from that acute critical ill situation to back to your homeostasis, and the way you can do that is by actually preventing underfeeding and overfeeding. This is very important because that's the only thing at that time. At that time, there's nothing more. After you have discharged your patient from here out to the wards, to the ward, from the ward to home, there's nothing more you can do. There's only ensuring that he is fed properly to an optimal level, and that optimal level is the question. How much is the actual energy that is required? That is the optimal level. So there are many methods, okay? There are many methods. There's something called direct calorimetry, there's something called first beat by beat method. This is to figure out your energy expenditure or resting energy expenditure, REE.
So before the patient becomes critically ill, the allostasis, can it come back to the normal homeostasis?
No, it cannot. It doesn't. It takes a long time. It takes a long time. So there are many equations that we look at when you look at resting energy expenditure. Okay, there are many equations. All right, there are many equations. There are equations. There are methods and there are equations. All right. This equation is what we normally use. 24 to 25 kilocalorie per kilogram is the expenditure, resting energy expenditure that we've been taking for a very, very long period of time. If it was so simple, the entire thing would have been very easy. Now let's take the example of a patient walking on the road traffic injury, head injury, okay, accident head injury, intubated, inotropic support, decompressive craniotomy, gets into meningitis, gets sympathetic storming, renal failure, CRRT, neuro rehab. How can it be always 25 kilocalorie per kilogram? Is it possible? It is not possible. You cannot have a single energy expenditure for it. It is not possible only. It is wrong to say something like this, I feel. In fact, even different diseases have got different. So not 25 kilocalorie per kilogram can't be even there for a single disease. Okay? Different diseases have a different. Look at this. So this is for traumatic brain injury. And look at sepsis over here. It's so different. You see, sepsis over here is different. Traumatic brain injury is different. It is different in a single disease also, for that matter. In a single disease also, it can be in different ranges, right? And not only that, it is different from all days. In all days also, the average energy expenditure is actually different. Not only that, sometimes you might say, okay, he's on the ventilator for longer period of time or lesser period of time, maybe the energy expenditure will be different. No, it's not like that also. If you look at it, at 3 days, there is energy expenditure that can be here, or can be here. We don't know. It is all different all the time. There is no similar. So it varies from disease to disease. We do not know the actual, for a disease, this is the energy expenditure. We don't know that. We don't know, it varies from individual to individual. What is your energy expenditure will be different from hers, right? It varies in the same individual from time to time. Morning there will be something, next day there will be something different, right? Cannot be predicted with severity of illness, and it cannot be predicted with the days of illness also. You can't say he's 4 days old or 10 days old or he may be severely catabolic. No, he has become severely catabolic, but it's very different. Okay, so let's think about this very beautiful paper that comes in. This is a paper that was done a while ago. Okay, very beautiful paper, only 6-7 years ago, which is actually the standard now. Okay, this is a doctor by the name of Warren Zussman. Warren Zussman and Pierre Singer worked with Pierre Singer. So it's a very famous hospital called as Petah Tikva Hospital in Israel, basically. And what they did was they looked at a whole lot of patients that were there. Okay, 1,000 patients over there, and they looked at various disease categories. If you look at it, there were various disease categories: surgical, trauma, medical, everything is there in that. The whole group of patients they looked at. And they looked at various severe, they're all very severe patients. 22 and 20 is the average Apache scores. Those severe patients only they looked at. And look at this 20 and 22. And what they plotted the delivered calories versus the resting energy expenditure. Matlab, if you have said, I want to give 1,000, okay, have you given 1,000? 1,000 divided by 1,000 is 1, no? So how much calories have you given? Delivered versus on the resting energy expenditure. So if you have delivered 100%, it will be 100%. Okay, if you delivered 100% of what was given, 100%. If you delivered only 40%, this is 40% of the resting energy expenditure. And here it looked at mortality. So if you delivered the whole resting energy expenditure, what happened? This is what they figured out. So till now we thought this different REEs, right? Our resting energy can be different for one patient, single disease. So what if you match it? What happens? So they looked at that. What they found was something very interesting. Protein wise, if you reduce the amount of proteins, the mortality actually goes higher and higher. Okay, so if you see the proteins are for 50% of the target, the mortality is high. When you reach 100%, the target gets better. Okay, the patient gets better. The protein requirements remain elevated. You cannot reduce your proteins. Your proteins have to remain like the way it's supposed to be done. There's no change in the proteins. Clear on this? Whereas what happens with calories is very interesting. What happens with calories is something like this. So as you go from 20% to 40% to 60%, the mortality is actually coming down. Right? The mortality is coming down. The mortality is coming down when you go from 20 to 40 to 60%. Once you reach 70%, after going from 70% of the calories, it starts going higher. Okay, after going 70%, it goes higher. What does this indicate? That 70% seems to be the sweet spot. Now you reach 70% of the resting energy expenditure, that's probably the time, that is exactly what you want. So in critically ill patients, these are the group of critically ill patients. So if you have a resting energy expenditure for 1000 that you're finding out, you probably want to give 700. You want to give 700. So 70% is what the requirements are. Anything more than 70% appears to be causing a problem, right? So this is a very important paper. 70% seems to be the right number when you're looking at the calories that you need to deliver with respect to resting energy expenditure. But in the first place, how do I know it? How do I know my resting energy expenditure? Okay, can we predict it? So if you look at when they predicted it, what happened? So you see this Harris-Benedict resting energy expenditure. This is a very old equation, 1919. 1919, Harris-Benedict came up with this equation. Okay, that equation was there. It's still in many hospitals. They use Harris-Benedict equation. There are 200 more equations. By now, there are more than 200 equations. Facey, Ireton-Jones, so many equations are there. But all those are predictive equations. And what we call as 25 kilocalorie per kilogram is called as simple predictive equation. You understand? That is simple predictive equation. Now, when they actually looked at Harris-Benedict and they looked at resting energy expenditure, there was a big difference. Look at this: 1944 versus 2304. So it doesn't appear that when you predict resting energy expenditure, you may do the right thing. It doesn't appear like that, right? Now, this is another study that we did. Okay, we also looked at something like this. We looked at adult ventilated patients for 172 patients. Okay, and we looked at that, and here again we found the same thing, that this was energy estimated with. So I use a simple predictive equation may potentially lead to overfeeding in mechanically ventilated patients. This is what we found. We found that if I use simple predictive equations, it may be very, very problematic. So it does appear that we should not use simple predictive equations by the looks of it. So predicting the kilocalories really does not work. It does not work. This is the underlying point that I want to put to you all. And for the right kilocalorie, we need to measure. There is nothing else but we need to measure. Okay, the question is how do we measure? So we measure it by various techniques, of which indirect calorimetry is what we are discussing. What are the various techniques of measurement? Do you all know? What are the various techniques of measurement? What is the gold standard if I want to know resting energy expenditure?
Right, now is indirect calorimetry.
The gold standard now, but what is actually the gold standard to which indirect calorimetry? It is indirect. No, it's indirect. It's not direct. It's not direct. You understand? It's indirect. We'll come to why it's indirect, but this is indirect. The gold standard is actually by using something called double labeled water. Doubly labeled water is what? What is doubly labeled water? There are two radioisotopes that are sent into your body. Okay, hydrogen and oxygen 18 and hydrogen 2 or something it's called. It goes inside. These isotopes go inside. It gets metabolized and it comes out. So 14 days later, you keep on taking the urine of this person and figure out how much isotopes are coming out. That will actually tell you a resting energy expenditure by putting it into a kind of an equation. That is called as doubly labeled water. Okay, deuterium isotopes are used for that. So doubly labeled water. So that's one form of finding resting energy expenditure. Obviously, we cannot wait for 14 days and 15 days to get our resting energy expenditure, right? We can't do that. So we cannot use doubly labeled water. What is the other method? The other methods that we have, you use your smartwatches. So in the smartwatches, you have heart rate variability. So it actually looks at your heart rate variability and gives you an energy expenditure. It gives you E, you have seen the E, energy expenditure in that. It actually gives you energy expenditure in the kilocalories it shows you. The kilocalories is based on first beat method. It's called first beat method, where it changes beat to beat, finds out the alterations, puts this in a software and gives you a resting energy expenditure. Not really confirmatory, If you don't have anything, maybe you can use that, but it's not really confirmatory. That is said. Then if there is indirect, there is direct. What is direct calorimetry? Direct calorimetry is you put a person in a room, run water around it, find how much heat is coming out, and that is your calories. You'll find out the calories that's coming out. So that's called direct calorimetry. So it needs a room. It needs a person who's sitting, not moving at all, because you have to have resting energy expenditure. If he moves, it will become activity induced. You can't eat that much. He has to remain that way. So you can't do that in the intensive care. You can't do it in normal person also. So that's called direct calorimetry. That's called direct calorimetry. You understand? So there are different kinds of calorimeters that you have. What we are doing is indirect calorimetry. Now what is indirect calorimetry? Every cell will breathe. When they breathe, they will consume oxygen and they will release carbon dioxide. This is what happens to every patient, every person, every cell that is over there. Okay, it will expire a certain volume of carbon dioxide, at the same time will consume a certain amount of oxygen. Okay, that's what is about indirect calorimetry. Does it really work? Does it really, and based on that, it puts it into an equation called as a Weyer's equation, which she showed. And the Weyer's equation, when you put Weyer's equation, you put VCO2, that is the consumption of oxygen, and VO2, that is, and VCO2, which is the expired carbon dioxide that's coming out. Put it into equation, you get resting energy expenditure. Is there evidence for this? Okay, so this is evidence that says that the ICU length of stay actually comes down when you actually use indirect calorimeter. Alright, so this is again showing the same thing that indicates that IC guided energy delivery significantly reduces short-term mortality in critically ill patient, actually reduces mortality also. Okay, there is a clear number of studies that they've done, 8 studies if you actually put them and say the mortality actually comes down. This is what it is. Okay, significantly reduces short-term mortality. Now this is one patient that we've actually reported in one of the journals. So if you look at this patient, okay, very interesting. This patient was admitted to us with a severe psychiatric deficit where she was not she had not eaten food at all. Psychiatric deficit, was admitted in our ICU. And then what happened was we started feeding her. At that time we didn't use indirect calorimeter. We thought it doesn't really make a difference. We had it but we weren't using it. Okay, so 25 kilocalorie per kilogram, and since she was not eating, we decided to start at 10, 12, 13 and we slowly went up to 25. We had 25 kilocalorie and this was 25. But surprisingly 3, 4, 5 times everything else, lung is normal, everything is normal, kidney is normal, everything is fine, but she's just not getting extubated. It was so difficult to extubate that lady, and then we used indirect calorimeter. We used indirect calorimeter, we found that the amount of prescribed nutrition was so high that it was actually increasing ventilatory overload. And then within 2 days, the patient actually was successfully extubated. This is a live patient that was there with us. Okay, it was very clear. We didn't do anything. We just reduced the energy consumption that she was, amount of food feed that we were giving, and she actually just came off. Okay, so this is a clear estimate of what this happens. Okay, this is the same case that we put up, and we have another study also. So in our study, what we did, we looked at all patients in the ICU and we looked at length of stays. Okay, and what we found was very interesting here. We found in the length of stay in 15 to 23. Look at this. With indirect calorimeters 4.95 versus 6.62, 6.60. Okay, there was a very good, and actually the best was length of stay on the ventilator. Look at this, 10 versus 13. That was actually reaching significance. Okay, it was reaching significance. So it appeared that in 15 to 23 category, 15 to 23 Apache score, at least in our study, we had a clear-cut reduction in length of stay. So this is data from India only. I want to say this data from abroad, Indian data, which actually says this basically, that indirect calorimetry kind of works. Now this is data from outside. Okay, Bath Jaconas Hospital in Jewish Barnes, that's at in US. They actually did this, and they found the average ICU length of stay was actually lower. Okay, ICU length of stay was lower when they looked at indirect calorimetry. So what happened was, they had a whole time when they were not using indirect calorimetry, and then they had a time when they were using indirect calorimetry. Okay, when they actually bought the devices. So they compared that and this, and they found out that the length of stay was very different, 6.83 versus 9.81. Clearly indicating length of stay being on the lower side. So there's no doubt about the fact that ICU length of stay comes down with indirect calorimetry. So would you titrate anything without monitoring? You will not titrate anything, right? BP, will you titrate BP without monitoring? No, you will actually put an NORAD, you will look whether the BP is getting proper or not, and then you will, you check your BP and then you will titrate the NORAD, right? So you should not titrate anything. Okay, when you're looking at energy expenditure. So that's why to find out the right kilocalorie, you have to use indirect calorimeter. You have to use indirect calorimeter, right? There's no other way that you can do this. Clear? Any questions? When we go to the device.
So the predictor equations.
Huh?
So that means we cannot use it for intensive care.
We shouldn't use. Ideally, we shouldn't use any of the predictive equations for intensive care. It is wrong to do that, because you will see that there is a big difference. So if you wanted a bird's eye view of the technology that we use, okay, this is the technology. The technology has actually advanced. No, it has advanced quite a bit, right? So the Swan GANs, which was technology, still gives us a lot of ideas as to what to do, what is VCO2, what is VO2. It gives a lot of things. Swan GANs, even if it is, they say don't use it. It actually helps us to learn physiology. You understand? So I would not say that it's not of use. It has helped us a lot to understand physiology. Okay, physiology has gone a great way. So understanding energy requirements, process of delivery, actual delivery, these are where nutrition is going forward. we're actually as time is going, we're understanding these things much better than what we were initially. And this is the various estimates I was telling you about. You have direct calorimetry, you have indirect calorimetry, you have first beat by beat method. This is one of those watches. You have bioelectrical impedance analysis, which actually also gives you energy expenditure. Medgem like devices, which are oral devices that you apply. Then there is this doubly labeled water, heart rate based estimation, which you use for your smartwatches. Right. So if you take it one by one, this is direct calorimetry. How does it look? This is very old, Donski's calorimeter. Okay, direct calorimeter. It was done long ago. Okay, 24-hour energy expenditure. What they do is they put you in a box. Okay, and then figure out it's a box. Patient lies inside the box. There is water jacket around the box. But there's a room like this. And then they figure out how much is the air, heat coming out, heat coming out. So they can put it in the equation and they get the answer where oxygen, carbon dioxide. This is how it is. Air is flowing into the chamber. There is a jacket of water around it. Airflow. Is this available? Yes, it is. There are institutes, and you cannot use it in many of these things. It depends on ethnicity. It depends on what the lean body mass is, fasting temperature, noise. You can't even have noise when this is going on. Time, there has to be a good period of resting. The gas analyzer calibration has to be done every 24 hours. So obviously you can't do this in intensive care. This is how it looks. This is direct calorimeter. So it's a huge room. You put the person in that room and then you figure out the calorie required. This is what is direct calorimetry. You can see this room, right? This is how direct calorimetry is done. So that's what the doubly labeled water is what I talked about, where you put a certain amount of H2 and O18 isotopes inside the body, and then you start monitoring the urine output, and you figure out what that is all about. Doubly labeled water. Okay, so it doesn't monitor the carbon dioxide elimination. Collection of a periodic urine has to be done. So it takes a long time to do that, but that is actually the gold standard. Okay, that's actually the way it's supposed to be done. Okay, then there's first beat to beat method. This is what you use. Beat to beat method is what you use when you are looking at your smartwatches. Okay, the smartwatches, it actually looks at how much is your RR and how much is your heart rate, and based on the variation of your heart rate and RR, puts it into an algorithm and gives you your energy expenditure. Again, not something that is advisable if you really want to do the right thing. But first beat method is the errors are very large when you compare to indirect calorimetry. Okay, so that's why what we do over here, this is called as bioelectrical impedance analysis. What we do in the intensive care is BI that we done in medical BI, that is in body estimate that we use. That is medical BI. It actually looks at lean body mass, which is a better estimate of energy expenditure, and it, the principle being a small current that is going in and figuring out whether there is problem. But there is a problem with BI because it cannot work when there is hyperhydration or fluid retention. It cannot work when there is extreme physical activity, and if the diet is not okay. If the diuretics have been used regularly, and again will cause too much of fluid shifts and BI will not work. Menstrual period also causes problem. Pregnancy, you can't use it. Body shape depends on very thin or very fat, also it will not work properly. Alright, so you have sensor wear worn armbands also. This is something like this, which is being used very regularly in Australia. Okay, this actually also is a technology which is being used abroad, which looks at something called accelerometer inside a galvanic skin temperature response and characteristics of the patient and gives you energy expenditure. This is technology. This is all technology that's being used all across the place. Sensor wear armbands. It's in research basically as of now, but this will be also coming in very quickly. Sensor based armbands. But what is exactly what we need to do is indirect calorimetry. This is the only thing that we can do if you look at all these techniques. Is it difficult? It is not really difficult. It is actually, you have to trust the machine very well in the first place. And when you look at my experience, it has been fantastic when I look at indirect calorimetry. How does it work? This is VO2. What is VO2? Minute ventilation. And this is the equation for VO2. Right? And VCO2 is VA, that is alveolar ventilation, PSO2 divided by K. This is the entire equation for figuring out whether there is. So this is modified into this equation where you have VO2 and VCO2. You might say VO2 is simple. VO2 is not simple. VO2 has a oxygen consumed. The volume, what you're looking at there is FiO2. It's a fraction of oxygen in percentages. You understand? VCO2 is a volume of carbon dioxide that is produced. It will all depend on the amount of alveolar ventilation that you have. Your VCO2. So it's not easy at all to find out VO2 and VCO2. That's why these devices are very expensive. Okay, so you're looking at VO2, you're looking at VCO2, and the machines, the older machines, I also work with them, is called as Delta Track. So it was called as Delta Track. It's no longer in production, no spare parts are available. I have seen the machine. Okay, Delta Track. This is Delta Track. Okay, Delta Track was a large machine. It required a large warming time. What happens in a Delta Track? The carbon dioxide oxygen that comes out is going into a mixing chamber. In the mixing chamber, it mixes, gets an average amount of VCO2 and VO2 that you have in that mixing chamber, and then based on that gives you VO2 and VCO2. That means the process requires recalibration very often. The process requires time because average steady state should be produced in that mixing chamber. And that is why it's a tedious process that takes place. Almost 1 hour warm up time is required in such cases, in this case. But what we use is our indirect calorimeter. So where is our indirect calorimeter, Amit? Here. We are using this. So where is it? Come here, show me, point it out. Where is our indirect calorimeter here? No, where is the indirect calorimeter? So, who's there? Here, come and see, where's the indirect calorimeter? Come sit. No, it's not the other one.
20 में है
नहीं, come and see the indirect calorimeter. सचिन, अभी इतना तुम लोग 3 साल से यूज करो, किधर है मीटर? आके दिखाओ मेरे को, किधर है मीटर? Come here. नहीं है, मेरे को पता मीटर किधर है? Where is your indirect calorimeter?
यहाँ से कनेक्ट किया हुआ है।
Where is your IC? I'm asking you, where is your monitor? IC. Where is your indirect calorimeter? Come go sit. So the indirect calorimeter is this small thing here. This small thing over here is indirect calorimeter. This is the module that you're using. This is the metabolic module. You're using this in the last how many years now? You're using 3 साल तो इधर है ना तो देखो ये नहीं पता यहाँ पर metabolic तुम्हारा. So your metabolic monitor is this one. This is your indirect calorimeter, right? What you're seeing over here is the readout. Okay, your metabolic monitor is this. It is a very small device that is applied to your mechanically ventilated patients. If you're going to use it with a CareScape R860, can it be used with other ventilators? No. It can be used only with CareScape R860. Okay, this particular ventilator that from GE, it can be used only with that. That only can be coupled with the indirect calorimeter. If you have a certain monitor of GE monitor, there also it can be put monitor of GE. Okay, monitor means the multi-para जैसा उनका एक GE का monitor आता है. In that you can apply that metabolic monitor. It is patented with them. This module is called as eCovix. COVYX. The module is called as Covix. eCovix. Okay, this is what is called. The module is called as eCovix. Okay, clear on this? So when you say we call it as metabolic monitor, but the actual term is eCovix. ऐसे बहुत सारे technologies है. Okay, there is something called Quark RMR. There's a technology called Quark RMR. Okay, this is just one before that. Okay, of different kind of companies. For example, this is Cosmed. Cosmed का first division was Quark RMR. Now this is called as QNRG plus. Okay, this is called as QNRG plus. This is what this is called as. What is this called as? QNRG plus. This is the metabolic monitor. Now I told you it is very difficult to actually find out VO2 and VCO2. Basic problem वो VO2 and VCO2 कैसे find out करना है. If we could have done VO2 VCO2 we don't need anything. उससे अपना फॉर्मूला में डाल दो पता कर लो. VO2 and VCO2 find out करना बहुत ज़्यादा कठिन है. It has to be the gas analyzer to be lightning fast. It should be able to fix the flows very quickly. Then only you can calculate VO2 and VCO2. Flows have to be picked up very quickly. The analyzer should analyze the amount of oxygen and carbon dioxide in that flow as quickly as possible, and then it can give you VO2 and VCO2. That's why the technology is very expensive. It's a very brilliant technology that you have, and the technology is based on these things. Okay, you have a paramagnetic sensor inside which is responsible for that fast reaction to gases as well as flows. That's a paramagnetic sensor that is there. Okay, you have this particular device. It's called Delight. Okay, it's a sensor which actually very high technology, which actually looks at flows at very microseconds. Okay, this is the one that goes from here into the device's spirometer. Okay, so the oxygen and carbon dioxide is then taken over there. Flows are assessed over here by the paramagnetic sensor. This is how we put it. Clear on this? So next time when you go and see the IC, see the attachments, how it is being attached. Okay, you have the HME filter. After that, you're having the Delight sensor. Okay, and this is called as a defend. There is something over here. This is called as defend. This is like a kind of a trap. Okay, so there's a defend over here. So whenever you are asking for indirect calorimeter with the CareScape R860 ventilator, the few consumables that you're using, which we are actually reusing, is defend sensor, D-light over here, D-light device, okay, and these green color tubings that come along with it. Okay, these green color tubings, this green and white tubing that comes along with it, this is what you're using, along with the metabolic monitor. Clear on this? Clear on this? So in sometimes, so when will you know your monitor is working? When you see VCO2. When you're seeing VCO2 means carbon dioxide जा रहा है, वो पकड़ रहा है carbon dioxide. The day you see the VCO2 is not being seen over there, it means this monitor is not working. You need to probably change your defend or delight cells. So that's also the reason that when you're actually keeping these monitors, ensure that there is no mist running into this. So if you keep this ahead of this, there will be mist running into this. If you keep this thing here, the HME filter will cause the mist to go inside that monitor. You understand? So don't keep this monitor, don't keep this over here. It's as simple as that. समझ में आ रहा है? Because it will have the mist running into it. Humidifier it is, no? So HME filter is a humidification device. It will run the mist into it and it will not give you the right readings. So paramagnetic sensor, you have the D light and the D fend and the tubings. This is the entire monitor, right? This is how it looks, isn't it, on the patient? This is how it looks into the patient. So whenever the monitor is not working, these carbon dioxide is not coming, look inside this tubing where the water has come inside. If water has come inside, it is not working. You cannot use it, you need to change it. Okay, these are disposables that come along with it. Clear on this? Yeah? This is the D-light sensor. D-light sensor. Right? So this is the device. Okay, this is what the device is about. So okay, this is the device that you see over here. This is, you see on all our ventilators. Our GE ventilators, all our GE ventilators has it. If it doesn't have it, it is available. Go and put it inside your ventilator. You can get it. Okay, so the only thing is that we are doing indirect calorimetry using the CareScape RH60 metabolic module, also called as Escovix. You have to have the patient mechanically ventilated. You can't have a spontaneously breathing patient to do this technology. Now, what is the difference between this and that then? Why this you are able to do and why that you are not able to do? Because it is the way they actually take out the VCO2 and VO2. Alright. Now, how does this ventilator, it's a little bit of a science, a little bit of a complicated science where this ventilator actually, because of the gas flows, it is taking on the paramagnetic sensor and it is taking that carbon dioxide oxygen gas analyzer from there. It is doing it there breath by breath. When we initially talked about direct calorimetry, we talked about what we call delta track, we said there was a mixing chamber. So there was a big mixing chamber of 5 liters. All the air used to go inside that. So if a person is breathing fast, it is not averaging out. If he is breathing slowly, is breathing that entire 5 liters is slowly averaging out, isn't it? It's slowly averaging out. So it was a mixing chamber that was done outside. फिर वो average वो VCO2 और VO2 उसमें से निकालता था. इसमें वैसा नहीं हो रहा है. इसमें क्या हो रहा है? Breath by breath वो VCO2 VO2 calculate कर रहा है. Breath by breath. You understand? Difference between that and this is the fact that that big mixing chamber has been technologically so super advanced to make it 2 ml of mixing chamber inside this. You understand? The difference is there it was breath by breath. That's why you needed all those sensors and D-light and D-fend and all those things. A metabolic monitor, a carbon dioxide oxygen that needs to be inside. Here, the mixing chamber that we talked about is a small device that is inside. It's a small device that's inside. That's 2 ml. It's only 2 ml. So the average you get quite quickly. You understand? The average parameters are quickly coming out. That's an improvement in technology. This is one of the few monitors that was not made by just technologists. This was made by doctors. When they were using the delta track, people using delta track all over the world, they realized that there are so many problems with delta track. It is so big, it is so difficult. It takes 30 minutes warm up time. It takes a long time before you get a reading. You have to recalibrate it. This calibration is done every single time. Mixing chambers are big. It is massive. It gets hot. So a lot of things were happening when we were using the delta track, right? So all these things were put together, and one ICALIC study group करके आता है. ICALIC is a very big study group of people who are interested in clinical nutrition, okay, which includes intensive care doctors, dietitians, physicians and surgeons and oncologists and things like that. A huge group, ICALIC group. They sat together and out of 3-4 years of understanding what they require in an ideal indirect calorimeter, they made this. So this is a doctor-produced product. It's not just a technologist product. It's a doctor-produced product who basically said this is how it should be, this is how it should be. Now what do they do? To figure out what is the right farm to understand oxygen and carbon dioxide kitna nikal raha hai, the way is mass spectroscopy. There's something called mass spectroscopy. That is the gold standard to find out how much oxygen or how much carbon dioxide is there inside. That is the gold standard. That's how they can compare कि बराबर पता कर रहा है क्या carbon dioxide, बराबर पता कर रहा है oxygen. Mass spectroscopy. This is the only device that has been tested with mass spectroscopy. That's why this becomes now the gold standard. Okay, this becomes the gold standard, right? This is the Iscovics monitor. Okay. Now, what does the Iscovic monitor? There are few things that you must do when before seeing the IC data, before seeing the data on the indirect calorimeter. Okay, there are a few things. You have to wait for it to warm up. It takes around 30 minutes for it to warm up. You put it inside, you wait for 30 minutes. After 30 minutes only the readings will come. Immediately the readings will not come. It will not come immediately. It will not come if the FiO2 is 0.7 and 0.8 and 100% and 0.9. उसमें नहीं आएगा. तुम 80% रखो, 90% रखो, 100% रखो, उसमें नहीं आएगा FiO2. It has to be somewhere around 60%. 60, 50, 40, 30. So you can't do it. Whereas this device you can do for 70%. This device you can do up to 70%. हाँ 70% तक कर सकते हैं. लेकिन बाकी जो हमारा ये जो device Iscovics इसको बोलते हैं, that can't be used if the FiO2 is more than 60%. It can't be used, right? You cannot use the device even if there is a tiny leak. So you must understand that that sensor is picking up micro mLs of gases. So even if there is a small leak in the circuit, it will give you a wrong result. It will not give you the right result. You understand? It will not give you the right result. That's why cuff leak should not be there, pneumothorax should not be there, ICD should not be there. They are all contraindications, right? Now, also you must understand what it is doing. It is actually looking at if this is your cell, okay, this is interstitium. You know, this alveolus is breathing and moving the carbon dioxide here and there, right? So, if your cardiac output increases, this will move and faster. This will occur faster and faster. If your BP for any reason goes haywire, this will again change. That is why if you're going to have alterations in your hemodynamics, you can't interpret your IC data. So for example, if your hemodynamics is going from 100 to 70, 100 to 120, you're actively changing your noradrenaline, at that time you can't really do IC data interpretation. You can't do that. You have to do IC data interpretation when there is no change of hemodynamics for at least 1 hour. Similarly, if I were to increase my FiO2, this amount of oxygen coming here will change. Again, this will again change. Amount of oxygen will change. So that's why if I am changing my ventilator settings and minute ventilation, which is changing the carbon dioxide or oxygen, I can't use an indirect calculator. So when I am taking out the results of IC, I should not have done any of these changes. Are you understanding? If I have done these changes and in the meantime I have gone and done my IC data interpretation, it is wrong. It is wrong. Okay, it has to be the period when the patient is actually something called as steady state. When I say steady state means he's not having fever, you're not excessively mobilizing him, you can't do it during physiotherapy, you can't do it when the patient's hemodynamics are altering, when the FiO2 requirements are changing, you can't do it. So it's important to do it only at the time when you are in a steady state. Moreover, you can't do it when the PEEP requirements are very high. Anything more than 10 or 12 PEEP, you can't do IC. Right? This holds the same for this one. So some patients also when they're using other gases, for example, if I'm using anesthetic gases, I'm using an anaconda in the circuit, I can't use the resting energy pressure from there because it's going to interfere, the gases are going to interfere. Nitric oxide I'm not going to use. So with nitric oxide anyways we don't use it, but nitric oxide if you're going to use for say pulmonary hypertension, you can't use it, you can't use IC. Okay, so this is what it looks. Now can you interpret these to me? Come. Let's interpret this. Okay. So this is how our IC data looks like. So in our ventilator, when we press this fork and from ICCM. So when you press this fork and spoon, now this is our ventilator. All our ventilators, all our Cascade R860s have got this this screen. On that screen, there is spontaneous breathing trial. There is functional residual capacity monitoring, that is end expiratory lung volume monitoring. There is this fork and spoon, which is basically the indirect calorimeter, and you have calculations. So now can you interpret these to us?
This is the volume of carbon dioxide which is expired. This is the volume of oxygen that is consumed. This is the respiratory quotient that will give you the value between, as I said in the morning also, 0.67 between to 1.2 is considered to be a normal respiratory quotient. VCO2 divided by VO2. This is the energy expenditure that comes in the kilocalorie. So it will be like a 20 kilocalorie or 22 kilocalorie, that will give you the volume.
So now what is the importance of the VCO2 and VO2?
It helps you calculate the resting energy expenditure.
So apart from that, it also can help you to understand what is happening to your ventilation. when you are ventilating your patients, what is happening? For example, what is your respiratory quotient? Your respiratory quotient is VCO2 divided by VO2. So if this equation becomes closer to 1.
Yes.
When equation goes closer to 1, what does that mean?
It's equal.
Equal
It's very
amount
equal
of-
to the amount of.
No, more than 1 if it becomes.
Consumption is equal.
More than one, then VCO2 might be increasing.
VCO2 is going up,
Yeah.
more than 1. So VCO2 is increasing means production of carbon dioxide is increasing.
Yes.
So from where does the production of carbon dioxide occur usually? From carbohydrates. So there is a possibility that your body is actually utilizing more of carbohydrates. Okay, that's all it is. समझ में आ रहा है? हाँ? Similarly, if this is less than 0.7, what does this mean? It's taking more of fats. It's utilizing more of fats. Substrate utilization का idea आता है. This is not 100%, but substrate utilization का idea आता है. That's what the RQ gives you. The second thing that the RQ gives you is it makes you understand the stability of your, we said a steady state, or the validity of an equation. The validity of equation is always there when your respiratory quotient is between 0.8 and 1. So if your respiratory quotient, your RQ here is your RQ here, see RQ here, can you see this? It is less than 0.6. This means this particular data is invalid. The data that you're seeing over here as 1712 is actually invalid. To have validity to your data, you need this to be 0.7, 0.8. 0.8 is normal. All of us are at 0.82. Okay, 0.82. This is what it should be. So 0.7 के ऊपर होना ही चाहिए RQ. So whenever you are ventilating your patients, at times you can actually look at what is happening to the VCO2 when you are ventilating your patients. If the VCO2 is going low, okay, the VCO2 is going low, and your tidal volume is going higher, means he's hyperventilating, no? But if your VCO2 is remaining the same and he's still hyperventilating, but it is tidal volume is going higher, what does that mean? It means that there is too much of carbohydrate in your diet. That is what it means. So how do you do this? ये कैसे करते हैं? इसको करने को कैसे करते हैं? So this was what you just now said. VCO2 you talk about VO2, you talk about energy expenditure, right? Then what do you do? Then after this what do you do? इसके बाद करते क्या हम लोग? ऐसा नहीं करते हैं. So what you do is then you find the steady state.
Coefficient of variation as well.
I'll explain to you now. Okay, so here you have. So what is here over here is your whole day. ये तुम्हारा ये जो चार्ट है ना, ये whole day का इधर है. ये जो मिनट में वॉल्यूम है MV. Okay, if your regular ventilation is up and down, it will not be steady. ऐसा ऊपर देखो या नीचे आ रहा है, फिर ऊपर जा रहा है, नीचे आ रहा है, फिर ऊपर जा नीचे आ रहा है. Regular ventilation keeps on changing. You are not getting the right numbers. समझ में आ रहा है? So you move. This is 30-minute window. So you are looking at a 30-minute steady state. You are searching for a 30-minute steady state in the first place. So I can move this like this. I can move this here and there to find out that steady state. I can't move it here. If I move it here, it is not right. If I move it here, maybe it is better. If I move it here, maybe it is better. I am searching for a steady state in the last 24 hours. Okay. So once I come and put it over here, it opens up that 30 minutes over here. Are you understanding? समझ में आ रहा है? It opens at 30 minutes, saying that okay, look for your steady state in this place. So once it opens up, for example, it has done this. It has opened up this, and this. Because you have taken this place. Now after this, what you're going to do? I'm going to see how much my oxygen and carbon dioxide are varying. It should not vary too much. It should vary less than 10%, less than 5%, less than 5%. So that time, what I'm going to do? I'm moving this cursor here and there to find out whether my VCO2 coefficient of variation and VO2 coefficient of variation is less than 5. That means if it is less than 5, it is not varying too much of oxygen, not varying too much of carbon dioxide. That is your steady state. When you have VO2 and VCO2 less than 5, VCO2 and VO2 less than 5, and your RQ 0.7 to 1, that equation now, whatever average energy expenditure you're getting, that is your right answer. समझ में आ रहा है? How I'm doing it? So when I touch my button, I'm first touching this button. I'm first touching this button which opens this screen. Then I'm touching this button to find my steady state. Second button I'm pressing. Once I get my steady state on this, then I'm coming down and searching for that 5-minute window where my VCO2 and VO2 will be varying less than 5%. Less than 5%. So when I see that at less than 5% and my RQ to be more than say 0.7, that is my average energy expenditure. That you can figure out. Your RQ is right here. Energy expenditure RQ. See this RQ? You can actually look at the graph here to figure out your RQ also. So you can get your RQ of that, and that will be your average energy expenditure. So you are finding the steady state. Understand? So what we can do is on this, we can actually find somebody's steady state. So here we will find a steady state. Come. So on this, how do we do it? Okay. Hello. Figure out micro perfusion, tissue hypoperfusion, VCO2 VO2 कितना निकल रहा है. और if you are patients in cardiac arrest, VCO2 VO2 एकदम ही कम हो जाएगा. अगर एकदम hypotension वाला VCO2 VO2 एकदम कम हो जाएगा. You will know exactly micro perfusion के साथ क्या हो रहा है. There is some improvement that we can see with that, all these things. Okay, now let's check out. So that was what we discussed was based on CareScape R860. Abhi the same indirect calorimeter energy expenditure can be done with COSMED. Now how do you switch on the machine? So there is an on and off over here. So this you switch it on, what comes here? So so first of all, what happens with that machine? With that machine, if you compare, we first put the metabolic monitor, and what happens? It warms up. It takes 30-35 minutes for it to warm up. It takes 30-35 minutes to warm up. This doesn't take that time. You put it on, and by the time you press yes, no, whatever, I just press close. New gas, another test can be performed. New gas analyzer है कि नहीं, वो सब पूछ रहा है आप लोगों को, and this opens up. You just say yes to everything, and then come here. This opens up. So when this opens up, what it is asking you? You want to do a new test, you want to review an old test, you want to calibrate, calibration is done once in a month. Gas analyzer calibration, flow calibration, that is a completely expert driven, not a clinical driven thing. It's an clinical expert driven, actually application specialist driven thing. So that is calibration, utility settings and QC, quality control. Okay, so what I want to do here, I want to do a new test. So when I press new test, it says new patient or search the old patient. So if I am doing it, searching the old patients, it will just look for the old patient, just press yes. I am seeing new patient, so I go to new patient. When I go to new patient, I put my last name here. So let's put Niharika. Mask karo tab tak. So Niharika, gender, female, height. What's your height?
164.
5'3",
What is
150.
154.
152
is fine.
152, ठीक है. So I put 152. That's important, okay? Because what it does is the screen gives you predicted kilocalories. No, it gives you PC. You understand what I'm saying? It gives you simple predictive equations का भी answer देता है वो. Based on that, so it's putting that. So it gives you a comparison कि भाई तुम्हारा predicted कितना है. Okay. So what's your weight? 70. So it gives you an ID 1, 2, 3, 4, 5. So just put an ID, okay? Now enter this. Okay. Now once it does this, what does it tell you? You can use either canopy mode, you can use ventilator mode, or you can use mask mode. Okay. What is the canopy? Can you remove the canopy from there? So the gold standard usually for IC is canopy. Gold standard. Okay. The gold standard is canopy. What is canopy? Canopy is like a hood. Okay. So yeah, that's the canopy. And there'll be a veil inside. Veil bhi रहेगा अंदर. Veil निकल. Plastic veil रहेगा. No, veil रहेगा. Veil. There'll be a plastic veil. Okay, I'll just show you this. So this, if you see this, no, this is a canopy. This is a canopy. वेल है क्या प्लास्टिक का? नहीं, एक व्हाइट कलर का शीट रहेगा उधर. Then एक प्लास्टिक का शीट है. वेल मतलब प्लास्टिक का एक शीट है. That plastic का sheet will just go all around, go tucked into the patient so that there is no leak from somewhere. That's the way. Simple plastic का sheet है. बाकी कुछ major नहीं है. It's just a plastic sheet. Yes, this is the one. So what does this plastic sheet do? Show me the plastic sheet. So you have that वो mannequin निकाल ऊपर से. Here you put the calorimeter like this. ठीक है? And then this veil will go through a hole in the veil. It goes like this, right? And this you tuck under the hand so that there is no air leak from somewhere. Okay. After you do this, there is a single hose. Show me that hose. And you apply this connection. There is another connection. This is not the connection. This connection will come here. This is for the patient to breathe out. And this will go into the device. This is all that you require. This is all that you require. Right? Now, remove the connection first. Clear on this? This is the canopy. Now what we're doing is a mask mode. So when it's a canopy mode, it will tell you attach all these things. Let's say ventilator mask mode, if it is mask mode, when it's a mask mode, see what it shows. It tells you what is to be done. Okay. Connect patient circuit while calibrating. So it is calibrating. When you're doing it, it's already started calibrating. Okay. So it says you apply this, attach this. So the patient, so from here attach it.
Over here, so there's a mark where to attach.
Be careful when you're doing it. Yeah. Be careful when you're doing this mark to mark. Okay. And then this will attach over here. Okay. So this is a patient. So when you're on a ventilator, in the inspiratory limb, you will attach one circuit because it has to take oxygen and it has to take carbon dioxide. It has to take both, right? So you will attach one to the inspiratory limb and one you will attach to the eyepiece. Simple. Okay. This device is also called as pneumotachograph. Pneumotacho. This is called pneumotach. Okay, it's called pneumotach. समझ में आ रहा है ना? Called pneumotach. So an ideal IC, the patient should be fasting for 12 hours, should not have taken caffeinated drinks. Ideal RC के लिए, okay, RE के लिए. Should not be taking caffeinated drinks, should not have exercised for at least 12 hours. Should not have exercised for at least 12 hours.
Carbonated also.
Carbonated drinks they cannot have because carbon dioxide produce हो जाएगा. Caffeine and carbon increase BMR. So the sound has come. Okay, this is a turbine based model. So what it is doing is it is actually to figure out it's actually blowing some air inside. Similarly, what it blows through that is air inside. It blows a small amount of air through this turbine that is there inside, and that air is responsible for figuring out what is inside, what is the cavity. It's basically mixing it inside the taking from there and mixing it inside the chamber inside this. All right. So saying let's say the start has come in a way. So you see this? Start has come. So if they start here, so now it starts simple. It starts collecting data. You see, it's collecting data now. Okay, and doesn't take more than 5 minutes to collect data. Okay, it starts collecting data. Now as she breathes, initially there will be a hyperventilation. So what I'm going to see over here is a little bit of hyperventilation. And that variability that we saw over there was here, VO2 and VCO2.
But that only comes after 2 to 3 minutes.
Yeah, it will come only after. Yeah, it will take around 4-5 minutes before it actually comes. For a canopy, what happens is you need to ensure that the gas is not the gas is not getting diluted too much. So when you put in canopy mode, there will be a blower that comes here. There will be a small blower which is basically the turbine. So अगर वो blower को हम लोग को 0.7 और 1 के बीच में रखने का है, तो fan increase करने का या decrease करने का based on that, so that it doesn't dilute too much. समझ में आ रहा है? तो blower करके आएगा इधर बाजू में. वो blower में क्या करना है हम लोग को? उसको press plus नहीं तो minus करना है, ताकि वो 0.7 और 1.1 के बीच में रहेगा. That's all you have to do. When you're using canopy. That will be the separate that will come here. Apart from this, that will come there. Right? So now the data started coming. See this data? This is the data that is coming. Okay. Now as the data is coming, there will be data points that will come in on this. So this is not right. Obviously this is not right because you don't have a variability. The RQ is 0.54. So it is going to slowly get, but within 5 minutes you will get the data as to what should be her resting energy expenditure. But you will have to just stop the test, and just like how we figured out the steady state there, you figure out the steady state. It's so simple. For a ventilated patient, what do? We have this called as pneumotach. This is called as pneumotach. This is flow REE. It's also called as flow REE.
That is also pneumotach.
This is pneumotach. This is also called as pneumotach, but it's also called as flow REE. It's called flow REE also. People call it, whether you speak to a specialist in indirect calorimeter, they will call it flow REE. But actually it's a pneumotach. Okay. What does a pneumotach do? It is basically, it's got a blue and a white code, very simple to do. Okay. So if you have a patient who's on the ventilator and you don't have the CAREScape R at 60, you don't have the CAREScape R at 60, right? All you do is you, wherever your, this will go right here. There is a blue and a white here. Blue and white, blue and white. Blue and white, blue and white. Right? Then there will be one that comes from the ventilator. The one that comes from the ventilator will come from the inspiratory port of the ventilator.
So this will remain like it is connected directly.
Yes. ये ऐसे इसके अंदर जाएगा, ऐसे इसके अंदर जाएगा, और ये इसका जो एंड है व्हाइट इसके अंदर जाएगा, इसका जो ब्लू है इसके अंदर जाएगा. That's all. This end of the circuit, inspiratory limb जो रहता है, inspiratory limb में put that because we want the O2, O2 what the flow and all these things. So inspiratory limb में ये जाएगा, and this will come, since this is coming from the ventilator, this will go to the port called as ventilator. See yellow color. You see that? We go to this end. Whereas on your HME filter, there will be a small port. On that HME filter, you attach this patient. This tube that is attached here will attach to the patient on that. So once you do that, you start measuring. Simple. It's not difficult at all. This is actually supposed to be disposable, but we normally reuse it. Okay. So now it is actually started to go up. Your RQ started to go to 0.9.
So what is use of this? Because it is connected to machine only.
So this is calibrating.
Okay, this is just for calibration.
This is calibrating everything we keep.
Okay.
You need 5 minutes, no? हम calibrate करना है ना? That machine is taking 30 minutes warm up and calibration. This machine is not taking that. As in fact, if you remember, as we were talking, it was calibrating. In mask में, as we were talking, it was calibrating. So by the time you applied the mask, calibration was done. You understand? So it's quick. It's not going to take time. So this compared to our CareScape R60, which you have to wait for 30 minutes, 35 minutes before you calibrate. So now what you're seeing now is this green mark is your energy expenditure. This violet or purple or is respiratory quotient, and your VO2 and your VCO2. You understand? It is now reaching a kind of no variation. There is no variation, only 0 and 0. Coefficient of variability 0 and 0 are filal. Okay. So as it goes, you will ensure that there is a whole data that is coming up. Once the data comes up, once you stop it, then just like how you did average steady state, you again look for average steady state here. But there you require 30 minutes. You require 30 minutes at least before you could get a reading, and then another 30-40 minutes before you could get some kind of average estimation. So 30 minutes में कुछ होता नहीं, उसको लगता है 1-2 घंटा जाएगा before you get that reading over there. Whereas here we are talking and the readings are almost going to be ready. You understand? So if we finish 1 minute maybe, in the 1 minute already we are seeing that RQ is 0.86, your resting energy is 1291, your VO2 is 1. We are seeing the whole reading coming over here. You understand? So if you stop it and you say I stop recording, I say stop, then you can actually check whether your average coefficient variability. समझ में आ रहा है? So let's take the example to stop it. Okay, I'm stopping it. I'm going to stop. Yes, I'm going to stop the test. So when I stop the test, what happens is it opens up this way, and now see it opens up this kind of window automatic. So its VO2 is less than 3, VCO2 is less than 4. So it's already taken the statistic over there. If you want, you can change it. You can actually move it if you want. If you want to, you say edit average. You say edit average, and I can move this. Like how we are moving the other one, right? So I'm saving this one. So I got this average 3 and 4. Her energy expenditure is 1,336. What did you eat yesterday? If you want to know whether she is going to be overweight or not, you just can ask what did she eat. What did you eat in the morning? Yesterday? Kal कुछ नहीं खाएगा. ठीक है Early morning को क्या खाया तूने? So it is giving you kilocalorie per kilogram per day here by saying her requirements are not 25. Her requirements are actually 19 kilocalorie per kilogram per day. It's not 25. You see, we just not talk simple predictive equations. 25 kilocalorie per kilogram. What is her requirement? 19. It's 19. It's not 25. So if you want to give her 25 kilocalorie per kilogram per day, she is bound to be overweight if she doesn't exercise. You understand? So 19 kilocalorie per kilogram is what she requires. Her VO2 is 190, which is kind of okay. VCO2 is 160, that's also okay. Predictive equation ki ho gaya na? So she's utilized 40% of fats and 60% of carbohydrates. Protein utilization will come only when you add urine, urea, nitrogen.
That again calculates and
You
then
calculate and give you. So this is fat and this is carbohydrate, right? So let's calculate how much she had now, just for the sake of this completion of discussion. What did you have yesterday? Morning ko kya breakfast hai?
Morning we had bread butter.
Morning you have bread butter. So how much does bread butter contain calories? How much butter did you have?
2 slices.
2 glass.
So, 2 slices of bread.
2 slices of bread.
And
Butter and chai.
And chai. So chai is also there. So you're reaching 240, 250. So 250 kilocalories, just added 250 kilocalories. This is for morning. What about breakfast? This was breakfast. Lunch? नहीं कल lunch
That's proper 2 chapati, 1 bhaji.
हाँ.
And that's it. and your night will be late.
So 2 chapatis and 1 bhaji. So you're reaching around 600, 500 calories. Not, oh, that's it. 2 chapatis and 1 bhaji.
सच्ची बोलो.
And rice. No, and rice.
Rice also you had lunch में.
How much rice?
Dinner में rice you had. So morning not more than 350 lunch. Because only
400.
vegetables and
And then tea? No tea at all?
in between 2 cups.
2 cups of tea. So let's put that 75 calories. हाँ? कितना हो गया? 150 calories add कर दो. Add another 500 for the night.
Anything
Huh?
else in between?
And
Chai,
that's it.
tuna.
Nothing else.
1000 calories.
150. So she's had 500 plus 500. That is provided she's had only so much amount.
1400.
Morning
Nahin,
breakfast she did not
Mark
have.
her, she doesn't.
No.
have
She,
that.
let's put the breakfast in place also and see. So 1000 हो गया. 1000, 1250.
1400.
1400. So you are actually having more than what you're supposed to consume. Yeah.
We don't have to connect anything.
Nothing to connect there. Nothing to connect there. This is only, and this is also not connected like this. This is not the attachment for it. There is another humidifier that comes.
Okay.
That humidifier needs to be attached over there, and the machine will tell you what is to be done all the time.
But some gas can go from here.
That's okay. That's okay. So it is taking average.
Okay.
That's why it's blowing and taking the average. So you don't want it to be airtight.
Okay.
हाँ तो ये पूरा एरिया नहीं होगा, ब्लोअर है उधर, सफोकेशन नहीं होता है, ब्लोअर है अंदर और ये एरिया बड़ा है, सो इट इज टेकिंग एवरेज इन दिस एरिया. समझ में आ रहा है? हाँ तो दैट इज ब्यूटी ऑफ द मशीन. तो थोड़ा सा अभी देखो इन दिस आल्सो इन द एनआईवी आल्सो देयर इज गोइंग टू बी सम लीक, बट इट इज स्टिल कैलकुलेटिंग एंड गिविंग यू. You understand? So there is a difference between this calorimeter, indirect calorimeter, and that. You understand? Because your mixing chamber is there inside this machine, which is not the situation with that, which is looking at it as gas breath to breath. Even if the breath slightly changes, you will not get the right answers. So
that machine,
Huh.
if we change it to an NIV mask,
it will not work. Leak.
So
So because see the technology over there is breath to breath. It changes from breath to breath, right? So if your breath has a small leak also, that gas analyzer will take that leak, no?
And here
This is not like that. This is a mixing chamber. So it is taking the carbon dioxide oxygen from anywhere, wherever it is, and it is mixing here to form a steady state. It is forming a steady state here. मतलब वो क्या कर रहा है, वहाँ से थोड़ा निकाल रहा है, यहाँ पर steady state form कर रहा है वो. It is not forming a steady state there. Whereas in this machine, we are forming the steady state in the cascade 160 breath by breath. Are you understanding? So if you cannot have that VCO to VO2 steady, which will occur when there is a leak, or when there is metabolic abnormality, or when there is too much of hemodynamic embarrassment, or too much of oxygen, or things like that, if there is too much of leak, or things like that, it will not give you the right reading. You understand? So this has made indirect calorimeter to be very, very simple. This is released only 2 years ago. During COVID, actually, people used this because it was very quick compared to the other machines that we had. This is just released at that time. It has gone through validation already, and now at this moment, indirect calorimeter is the gold standard. I think this is very close to the gold standard. I feel to the ideal indirect calorimeter, very close. Any questions further? I see.
So this helps in pre-op and post-op patients like on
Tremendously. I mean, there is nothing, you cannot even compare how much this can help. So, I'll give you an example. So, you have patients that come in from OT, no? You have patients that come from who basically are oncology. When they go for operation theatre, they are already lost by 7-8% of their body weight. 10% body weight is lost. 10% body weight is lost. You do their bioelectrical impedance analysis, you'll find the skeletal muscle indexes to be very low, 5 and 4 and 3. You'll find that it is impossible. Have you even tried this? I am doing it regularly, so I can tell you. Okay, that if you have a patient who's coming after surgery, when they go home, they cannot even consume 10% of what you are measuring over here. For example, you have a gastrectomy that is done. When you do a gastrectomy, the amount of volume that you have in your stomach is 1 liter. Now you remove the stomach out. Now this patient has to eat the same amount of food. Can he eat the amount of food? Can he eat the chapati bhaji that she was eating? Impossible. He can't eat more than 1.5 cup. 1.5 cup of vegetable. 1 cup vegetable. Now 1 cup vegetable, the best of your vegetables will also contain maximum 150 kilocalories. Okay, you add the best of your proteins, let it be peas, green peas and Brussels sprouts. It will be 7 grams of protein. 1 egg will be how much? 6 grams of protein and maybe somewhere around 70 kilocalories of energy. So to reach 1300, which is normal, which is kind of very normal for anyone, 1300 kilocalories, can you even reach that with this diet? Are you understanding? So is it any time possible for you to have a normal diet, a home diet after a gastrectomy and achieve calorie requirements? Never. So for that you require to be seeking the help of very good dietitians who will take care of all these things so that you have good amount of hyperphagia that is happening, good amount of calories, good amount of proteins. It is impossible otherwise. Do you understand? So if you see a sample diet that I make for any of these post-op patients, you will understand how difficult it is to maintain. It's very, very difficult. So this can be done. So what happens is if a patient comes 10 days, you need at least 10 days. For any diet to do any work, no. For at least pre-op, what is known is that for operative procedures, you need 10 days. You need 10 days. So 10 days, so when is the right time when the patient should come? The patient first comes to the surgeon, that is the time the patient should be referred immediately. When the person is immediately referred, biotic impedance कर लिया तो हमारे पास एक standard आ गया. Like for example, we can switch this off now.